Good morning, everyone, and welcome to Oncology Academic Forum. The topic for discussion today is cancer prevention and screening, and we are privileged to have with us Dr. Abhishek Shankar, sir. Sir is Associate Professor in the Department of Radiation Oncology at AIIMS Patna, and he is the Associate Editor of Asian Pacific Journal of Cancer Prevention, and he's the Editor-in-Chief of Asian Pacific Journal of Cancer Care. He is the founder secretary of the Indian Society of Clinical Oncology, and he has received many national and international awards, and he is a member and chair of many national and international committees. He is the first Indian to be awarded the IGCS award for his exemplary work in oncology. So we wish you all a happy Teachers' Day, and thank you, sir, for accepting our invitation. And over to you, sir.
Thank you so much for this invitation. And I think on Teachers' Day, talking about cancer prevention and screening to people who belong to the subject of radiation oncology, I am not sure whether how much importance you give to this important area, because this is one of the most important area when you talk about the cancer care, but it is often ignored. Probably one thing from radiation oncology, we have given our attention to another important area, which is chemotherapy. And I think radiation oncology had started, working on palliative care, but I think it was again snatched by people from anesthesia. So now cancer prevention screening is an important domain because we are struggling hard to be called as a primary cancer care physician, which is not happening for many years now. So this is an important domain where you can work in the community or not necessarily in the community. This is one of the domain, but yes, you can start with the services, which is important to diagnose cancer at early stage in form of screening, making people more aware about this so that they can present early to the hospital and get them diagnosed at the earliest stage. And we all know the success in cancer care lies with an early detection so that you can cure the disease and you can make your patient survive. And then you can talk largely about the cancer survivorship, which is not happening in the larger way in India. So I will be talking about cancer prevention and screening. So I have nothing to disclose as far as this presentation is concerned. So many of you, I think, won't be aware what is the cancer statistics in India. If you ask, and I'm sure that your bosses or professor won't be aware about this, because we don't have a concern. And I personally feel that until and unless you have an idea what is the burden of the cancer or what is the problem, you will never reach to a solution, and nobody's at all bothering about what is the solution to cancer care in India. So prevalence is 42 lakhs. This is, I am quoting the ICMR data, which was published in 2016, with the 2012 to 2014, they have done the analysis of the total number of cases. So at one point of time, there are 42 lakhs cancer patients in India. Every year you see 7.36 lakhs new cancer patient. So 14.5 lakh new cancer patient, and every year 7.36 lakh cancer patient die because of it. So most common age which is suffering from this disease is 35 to 64 years, where you see 60 to 70% of total cancer patient lies in this age group. And we all know that tobacco related cancer is gaining importance in a country like India, like another low and middle income countries. So it is up to now it is 30 to 40%. And in the few areas, like you talk about the northeastern states, is between 40 to 50%. So 2/3 of the cases, we know that comes in the advanced stages where we don't have anything to offer except palliation. So breast cancer has become the #1 cancer in the country. And the biggest worry is now the rising incidence of the lung cancer. Cervical cancer is almost static cancer because we are not finding any significant rise in the total number of cases. If you talk about one subsides of the head and neck cancer, it's the oral cancer. But if you take head and neck cancer overall, it is the most common cancer in people, taking men and women together into account. So, what is Avalanche? What we see actually. So, we see the location. We are very happy to go to the very different area, which looks very fancy, which look glamorous, but it tells about the perspectivism. But we are not, sure or not worried about the relativism, which is more important when you design the cancer care in country like India. So context is very important. So we need to contextualize the community people live in. So if you want to design a good and effective and impactful cancer care in country like India, we need to think about the context. So whenever I ask anybody, do you think cancer prevention and screening are important in cancer care in Indian context? Probably most of the people, and I can say all, say that yes, it is very important. It is the backbone, and if we don't, it is important for Indian context. So next question, when I ask, how much time do you give in such efforts in your practice? And people say measurable fail to do good in this question, and they say no, we hardly have time. And I can understand people are very busy in giving treatment in form of radiotherapy and chemotherapy, and nobody is really bothered about what needs to be done in cancer prevention and screening. One thing is knowledge, attitude. Many of the people don't have even knowledge. They think that that is called pseudo knowledge. The doctors are, you know, aware about something. Yes, cancer prevention is important. Breast cancer, there is a screening modality. But if you ask them about the evidences and the current practices, they won't be able to tell you the right answer. So this is very important slide, and everybody has to understand it. If you think about doing something at the community level, probably over the period of time we have been very, very selfish, and we have adopted the individual oriented preventive action. So to deal with the health hazards, so what we do, we just concentrate on the outcome, but we never bother about socio-cultural determinants, which is actually causing the disease. So we lack attention here. So when you want to have a significant difference as far as the cancer care in India, rather than taking the individual oriented preventive action, you need to have a community or population based approach. Then, and you have to work on the socio-cultural determinants to have a concentrated and sustained social policy. Then only we can expect the social justice, to work against all odds to improve all odds. I give you a simple example, being a cancer specialist, whenever you go to any area and you just observe them about their practices, after some point of time, you will be able to tell them, yes, this kind of cancers will be more common in those, population. Whenever you go to northeastern part, you won't find any woman is, chewing tobacco, eating pan, during office hours, but go to northeastern states, this is their habit. And now with this habit, northeast states, few of the places having the highest cancer incidence in India. So you have to observe the socio-cultural factors, and you will come to know about, you observe the risk factors, and you can tell, okay, this kind of cancer will be more common based on their practices. So this is, important slides to address. I don't want to, advertise any Hollywood movie, and I'm not a big fan of Angelina Jolie. But this is a great example. You ask anybody, people are not, knowing more about their own wife, but they have a fairly good idea about what kind of genetic, mutation Angelina Jolie were having. So initially, I thought to call her mother of cancer prevention. But it's so difficult for a male to call Angelina Jolie a mother. So I thought to call her the lady of cancer prevention. So this kind of awareness drive is required. And second best example, this slide I think choose before Corona times. Now you can easily understand what is the impact of media houses when they decide to reach people and make them aware about an important topic. COVID 19 can be the best example where now everybody knows about what kind of variant we are having, about the vaccine. They has a clear cut distinction about what is co-vaccine, what is Covishield, what is the efficacy of a vaccine. I think we don't belong to that much of aware population where people are so curious to know about so much. So this kind of awareness drive is required as far as cancer care is concerned. People still don't know much about cancer. So important topic is concerned. These are the four important domain which is we need to consider to make people aware. Cancer is a science. Many of us, because we are doctors and we are dealing with cancer, so we always think cancer is a science. But many of the times you will find a person who is coming to you for to show their relatives. They will talk like this, that you will understand they have no idea what cancer is. So cancer, philosophy is an important thing that helps you to deal with many life problems and you can sort it out. But whenever it is cancer, you need to adopt a evidence-based practice, and philosophy will help you to deal other problems, but it is not applicable in cancer. And cancer, you get only one chance to get it cured, and if you miss that chance by any means, you will never ever correct the disease. So cancer is a socio-cultural disease. I have explained you right now. So there is a fight between evidence and philosophy. As a doctor, we follow the evidence. Outside you go, even in your relatives, in your society, people take it as a philosophical disease. And they try to solve this problem with their philosophy. And India is a beautiful country where nobody will give you anything free except advices. So this is our strength. So we are expert in giving advices to each other, and you can experience this beauty in your day-to-day practice. CAM and Ayush in cancer treatment is a big debate because many of the people feel that CAM and Ayush, complementary and alternative medicine, is a term used in the United States of America for Ayurvedic, homeopathic, and what kind of alternative therapies. Here in India, it's called as Ayush. So we need to make people more about the indication of CAM and Ayush in cancer treatment. So, so why prevention? I will just skip few slides. Hmm, I think I change it. So coming to the breast cancer, why it is important to talk about breast cancer. So everybody know that we need to make people aware about breast cancer, sign and symptoms. As a cancer specialist, every one of you know that what is the sign and symptoms for the breast cancer. You need to tell your patient and take this opportunity to educate the cancer patient to become brand ambassadors, so that they can nicely explain what was the first symptom they had, how they approached to a doctor, and they can discuss the successful story. And I can tell you that works among the community. So chemoprophylaxis is mainly in terms of vaccine, but till now there is no such vaccine which is effective. As far as breast cancer is concerned, there is a trial going on in Washington University, but still we are waiting for the data, what will be the final outcome. So when we talk about the secondary prevention, which is early diagnosis and treatment, so we will talk about early diagnosis, which is done by screening. So these are the modality which has been tabled to screen breast cancer. First is the breast self-examination, which is most commonly practiced by Indians. So we always tell that, okay, we are a resource limited country, so something is better than nothing. So for cancer diseases, if you want to screen somebody and give this opportunity to diagnose the disease early, breast self-examination is nowhere practiced. Because what is screening? Screening is a one modality, whatever the test in form of blood test, in form of radiology, and that is the most common feature which is required, that by doing screening, it should give you a survival advantage. Then only there is a need to practice it. Otherwise, you keep on practicing, but you detect the disease at the advanced stages. So there is no point doing it. So it should help you in detecting the disease early, and moreover, it should reduce the chances of dying from that particular cancer. So breast self-examination and clinical breast examination are the two modalities which is used for breast cancer screening. But still, they have not given any, reduction in, mortality from breast cancer. So standard is mammography, which is practiced, and there are recommendation to do the mammography for the different age group that I will be covering later on. Digital breast tomosynthesis, MRI, there are indication for MRI, and tertiary prevention, which is the disability limitation, which we are referring the patient to the Department of Anesthesia. So breast self-examination, there are many articles, have been many debates, but overall, what is the recommendation right now? That breast self-examination is not recommended as a standard screening tool for to you know for breast cancer. This examination, there have been a lot of studies on clinical breast examination. This is study which shown the positive side of it, which is it is called Mumbai study, which was done with the help of Rangaswamy Shankar, which is who used to work from the IR. Is a radiation oncologist, and he used to head the screening group, early detection and prevention section of IR Lyon, France, which is a part of World Health Organization. So this study, by doing the clinical breast examination, they proven that yes, it was helpful in detecting the lung breast cancer early. There was a probability, more probability of detecting axillary negative lymph node. It helps people to undergo breast conservation surgery. And there was one finding that yes, the chances of chemotherapy also decreased by 24%. So these are the findings based on that. Now, after that, the topper was added by Dr. Shankar Narayan. He just conducted the cluster design study in one of the cohort in South India. And now they are ready with the result. And they have, estimated that yes, it helps you to detect breast cancer at early stage, and it is also giving a survival advantage. So probably in coming days, in a resource limited setup, it might be a standard for breast cancer screening if it is done in the proper manner. So mammography is standard, and there have been many articles. So the important to notice breast cancer screening, the viewpoint for the IR, and they have nicely tabulated which is the age group which gives you the best survival advantage, and there are evidence available for that. So 40 to 50 years, you have to take decision that you have want to go for it or not. But yes, 50 to 75, 4 years of age, there are sufficient evidence that yes, if you just go for the mammography, it helps you to reduce the chances of mortality from the breast cancer. So other 40 to 44 years, there's a limited data. 44 to 49 years, limited data about the mortality benefit. So these are the further about the mammography, clinical breast examination, breast self-examination, and you can find there is no the evidence are inadequate to level it to suggest somebody to go for breast self-examination or clinical breast examination. So those are the screening guidelines for women, by the different agency. US Preventive Services Task Force and American Cancer Society are the two important agencies which we follow, because they update their guideline at the regular basis. So you can see that, if I will come, in the latest slides, what is the guideline by the Indian government when we started with the framework for common cancers in India. So this you can, I will share the slide. You can read about this. So breast cancer screening. Now, what is the benefit? So mammography may reduce mortality in age group 50 to 74. Clinical breast examination, we know that it has limited evidence, and self breast examination, there is no effect in the mortality. So harm for the any radiological procedure or clinical breast examination and the self breast examination, it leads to overdiagnosis, false positive, false negative. And if you talk about the any modality which is dealing with the radiation, I think radiation related harm you can see in the later part of life. So coming to the cervical cancer, this is the second important cancer which will level that it is the Indian centric cancer. So government of India has made three common cancers in India, although there are many. So cervical cancer, oral cancer, and the breast cancer. So those are the primary. You have to talk about the cervical cancer education. You have to make people aware about, cervical cancer sign and symptoms. And I think still many of the people are confused. What is cervical? Many people have come forward to me and told me that I have taken the cervical vaccine. Probably I will never have cervical neck pain. So people have poor understanding what is cervical. It's not about the people who are not educated. I'm talking about, reference in, the people who are highly educated. So we need to make, you can understand how people, it is the most required things to educate people. So cervical cancer vaccine, I will discuss it in detail. So these are the, screening modality which is advisable, which is well inspection with acetic acid, pap test, HPV DNA. So this is about the HPV screening, which is the most common, evidence from India. This was again IAC study, which was done in the cluster randomized trial, you know 52 clusters of villages, and they have concluded that yes, HPV DNA and pap test is important one, but in a low resource setting, single round of VIA can be a cost effective modality to screen cervical cancer in community based setup. So this is again human papilloma DNA versus pap test. So this is best evidence for that. HPV DNA is the best test to have. It tells about the infection and it categorizes further the subtypes of HPV which you are, in which you are having infection with, and you can calculate the risk from there. So those are the methods of cervical cancer screening. So what is standard? If there are the two setups. Somebody comes to you, you're working in a medical college, which is a tertiary care center, and they tell, money is not a constraint, and I want to get myself screened for cervical cancer. Probably you should offer the core testing, which is, getting, if they are more than 30 years of age, you should advise them to go for the HPV DNA plus pap test. And probably you have to repeat the test after 5 years. If you are between 21 to 30, the standard recommendation is pap test, and you have to just repeat the test every year. These are the, the calculations. So if you do pap test HPV DNA alone, nearly 1 out of 5 cases of cancer were missed by HPV alone testing. If you do the pap testing alone, more than 1 out of 10 cases will be missed. And if you do the core testing, there's a clear cut benefit that less than 1 out of 10 cases of cancer will be missed by core testing. So a standard recommendation in a hospital-based setup is core testing. If they are more than 30 years of age, 21 to 30, it is advisable to go for pap test. And if you are thinking about the community-based, cancer screening for cervical cancer, probably it is recommended to go for VIA. So this is again cervical cancer recommendation. What is the age? You should start with the 21 years of age, and how it changes over the, if you progress in your age, less than 21, 21 to 29, 30 to 64. So coming to the head and neck cancer, which is one of the most important cancer, if we talk about our country. So those are the established risk factors: smoking, alcohol use, but liquid, tobacco, viruses, diet, UV radiation, and few are emerging, which is the role of oral microbiome, which talks about the inflammatory cure and host genetics and the family history. So I will just skip the slides because you all know, if I have to teach you what is the role of smoking in head and neck cancer, probably I think everyone of us knows about it. So there are more than 70 carcinogens. You have to see the intensity and frequency of smoking. They're directly related with the causation of the head and neck cancer. So alcohol, again, it is very important group 1 carcinogens. Ethanol converts to the acetaldehyde, which is important factor in causing the damage to the mucosa. So when there is they have smoking and alcohol has multiplicative interaction. That means the joint effect is much high than the product of the individual effects. So those are the various study, and if you just think about the risk estimate where you choose betel quid, you take betel quid. There are 36 study and a cumulative risk estimate was 7.2, and the betel quid plus tobacco, it was, derived from the 31 studies. It was 4.1. It was published in the International Journal of Cancer by Guha. And this is an important slide to remember. Now, many of you, whenever I ask anybody that, tell me the HPV associated cancer. So many of the people just talk about cervical and moreover oropharyngeal. So these are the listed cancer which is contributed by human papilloma virus infection. So now, if you just take care of the infection with the HPV, you may protect yourself. If you're female, probably 5 cancer. If you're male, then related to the cancers in male and female. So totally 6 cancers are associated with the human papilloma virus, and their percentage attribution is different. And the most common subtypes which is associated with the cancer is HPV 16 and 18. So these are the anatomy of the oropharynx, oral cavity. So this is the HPV. What is the causal model? So sexual behavior, oral sex, and there are 5 to 10 times to have the oral or oropharyngeal HPV infection. So HPV associated 50 to 100 times in a person who are infected with the HPV. So this is another virus, Epstein Barr virus, which is majorly causing the nasopharyngeal carcinoma. So other risk factors, diet low in fruit and vegetables, but the risk and the benefits is not clear. If you take fruits and vegetables, you will not have head and neck cancer. This is not yet clear. So oral health and hygiene, poor hygiene and tooth loss, the role of microbiome, family history of head and neck cancer. There are few rare genetic disorders like Fanconi anemia, dyskeratosis, congenita, Plummer-Vinson syndrome. You have more propensity to have the head and neck cancer. So this is the summary of the risk factors. If you smoke, the risk estimate is 5 times. If you take alcohol without smoking, it is twice. But this is the multiplicative effect that if you do smoking and alcohol, the risk is 25 times. Tobacco and betel quid chewing, 5 to 10 times. Rare genetic disorders, 100 times. And human papilloma virus, 5 to 200 times. So this is the clinical picture, and this is a correlative histopathology that how leukoplegia looks like, then how non-homogeneous leukoplegia look like, and how it converts to the erythroplakia, and how you can differentiate between the erythroplakia and cancer on visual examination. So this is natural history, normal mucosa. You are exposed to the risk factor over the period of time. You precursor with with or without dysplasia, and there are always a debate that what is the chances of if you develop the dysplasia in the mucosa, is it all dysplasia will convert into the cancer? The answer is no. The progression is very much variable and depends on many of the factors, so you have to observe that. So these are the summary of 14 studies with the 992 oral dysplasia patient. Follow-up was 1.5 to 9.3 years. And you can see that the progression to cancer was 0 to 36%. So in the pool data, the progression rate was 12.1%. And what was the rate per year was 1.73%. So if you observe any dysplasia, the best way to just have a close follow-up, because all the dysplasia never progresses to the invasive cancer. So these are the predictors by which you can measure the progression, like it's a homogeneous or non-homogeneous, what is the size, it increasing or decreasing, dysplasia, location, the age, the female gender. So these are the factors on which you just predict the prediction of a lesion. So this is the summary. They have a progression 1 to 2% per year. Mostly clinical series, they have overestimated it, and few population-based study out of that study of 14, I have shown that they have underestimated. So only one, there are many cancers where you talk about the genetic, but when it comes to head and neck cancer, Only validated molecular marker till date is loss of heterozygosity at 3p, 9p, and 17p. So coming to the prevention, which is the most important aspect when you talk about head and neck cancer. So you have to, if alcohol and the smoking causes and tobacco use causes this, you have to just, you know, use the tobacco and the alcohol cessation strategy. What is the role of HPV? I think very high efficacy against xenogenital HPV persistent. So 90% efficacy for the oral HPV prevalence 4 years after vaccination. So what is the rationale to doing the secondary prevention? You just treat the leukoplakia pre-malignant lesion so it can be progressed to the cancer. Early detection through screening, which we have only one method, which is oral visual examination. And there is a one evidence to it, which is the Kerala, again, Shankar. They did the 4 rounds of visual inspection with oral visual examination and in the high risk patient, and they concluded that oral visual screening can reduce mortality in high risk individual and has a potential to preventing at least 37,000 oral cancer deaths worldwide. So there's no effective screening on reduced incidence, low efficacy of surgical intervention for the precaution lesion, and this is the screening cancer detection early stage. And as I said, if you do the screening in high risk individual who are tobacco chewers, that can reduce oral cancer mortality. And if you take about the worldwide data, that can prevent the death of 37,000 oral cancer patients. So as far as the US Preventive Services Task Force recommendation, they don't recommend anything about, oral cancer screening. So I think somebody has. Please mute. I think it happens when you're at home. Okay, should I continue?
Yes, sir.
Okay, so coming to the lung cancer. Lung cancer is an important cancer in the Western world, but India should not be happy right now because now incidents are increasing and it's growing every year. So right now, apart from the smoking, the other factors which is contributing in the low and middle income country, and especially India, because probably we are, as far as you must have heard about many WHO report that now 9 out of 10 world most polluted city are from India. So probably 2P is a problem to our country. One is population and one is pollution. So those two things are related to each other. And probably in coming days, we will be number one in this 2P. And probably right now, China is the most populous country in the world. But in coming days, we want to be the number one in this. So population and pollution, we will have the monopoly. We will always be number one. And that leads to many of the, diseases. And lung cancer is, most common more common in an area where you have the more polluted environment. So apart from the smoking, environmental factors has added as a risk factor of lung cancer. So screening in lung cancer, chest radiography, sputum cytology, lodosity biomarkers. So chest radiography and sputum cytology are no more used as a screening in lung cancer. So what is standard is low-dose CT scan. These are the recommendation by the various groups, and they tell that it was the previously before 2021, the guideline was to screen 55 to 79 years of age with 30 pack year smoking history. But in 2021, based on the recommendation by the working group in 2020, now this age group has been, reduced to 50. So you have to start screening at the age of 50, and that 30 pack year smoking history has now been reduced to 20 pack year history. So these are the changes, latest changes in US Preventive Services Task Force. So you should have a history of when to stop uh, screening for lung cancer. You are a current smoker and have quit smoking within 15 years. So if you have more than 15 years quitting history, probably you don't need to go for the lung cancer screening. So this we have published in the Translational Lung Cancer Research. It is one of the good journal. So we have summarized the, what kind of evidences we have for the lung cancer screening. So most important landmark trial is the National Lung Screening Trial, with you can see the participants more than 50,000, and they advise the low dose CT scan annually for 3 years versus chest radiograph. And this has been recently changed. So what was the recommendation? It was 50 to 75 years, 30 back years, and they found that yes, if you just go for the low dose CT scan in smokers, probably it gives a mortality advantage of 20%. The second important study is the Belgium Dutch trial, which is Nelson trial, and they again baseline, then after 2 and 5.5 years, this was no chest radiograph. So you can see the mortality benefits in men was 26% and in women was 61% in a follow-up of 10 years. Other are the UK lung screening trials, there are the Brazilian trials. You can go through this. But if somebody talks about the lung cancer screening, probably these two are the landmark trial. First is the National Lung Screening Trial, which gave boost to the recommendation of low-dose CT scan as a screening modality for the lung cancer. And second in line is the Nelson trial. So this is the ongoing lung cancer screening in every country, and probably you won't find the name any trial which is undergoing in a country like India. This is a big country. Lung cancer incidence is rising, but still there is no ongoing lung cancer screening trial. So this is a recommendation for every country, like what Japan, what Saudi Arabia recommend to go for lung cancer screening, along with the various society like American Academy of Family Medicine. But now the latest recommendation, somebody asks you from the US Preventive Task Force, you have to advise screening 50 to 79 years of age with equal or more than 20 pack year smoking history. So this we published in 2019, how environment and occupation is related to lung cancer. And second one, in the same journal, in the same week, we published another article, the feasibility of lung cancer screening in developed countries. What are the challenges, opportunity, and way forward? And in India, as far as the lung cancer screening is concerned, I can say we have a long way to go. So coming to the prostate cancer, which is another important cancer, during the time of independence, we had a life expectancy of 31 years. Now it is nearly 70%. So we all know if we, older population is larger in number and you grow older, chances of prostate cancer increases. So these are the two prostate cancer screening modality, digital rectal examination and PSA. So this is, but now US Preventive Services Task Force has clearly said in their recommendation that PSA is not a standard modality to screen prostate cancer, because over the period of time, it is not helpful in giving you a mortality advantage from prostate cancer. So digital rectal, these are the recommendation. Apart from the US Preventive Services Task Force, American Cancer Society, American College of Physicians, American Urological Association, they all recommend to go for the prostate, specific antigen estimation as a screening modality for prostate cancer. Colorectal cancer, this is the, now coming important cancer in India. In male, it's the third most common cancers now. So there are two kind of tests. One is with the endoscopy, second is with the, stool-based test. So sigmoidoscopy every 5 years, colonoscopy every 10 years, double contrast barium enema every 5 years, CT colonography every 5 years. So whatever the stool-based test, it is advised to go for every year, except the stool DNA test, which is advised every 3 years. So coming to the important thing, which we talk about the vaccine. We in India, in 2008, we started the bivalent and quadrivalent vaccine was licensed in India. In 2009, I think there was 2 demonstration studies, which was backed by IARC in Lyon. So they started 2 places in Andhra Pradesh and Gujarat. And I think 7 deaths were reported, 5 and 2 in Andhra and Gujarat, which was not related to the vaccination, but that really destroyed the future of cervical cancer vaccine in India. there was so much of litigation, and that, everything was stopped. So India had multi-center study on 2 or 3 doses of HPV vaccine. They started recruiting the girl in 2009. After this, controversy related to the 7 death, I think in 2010, HPV vaccination drive was suspended in research studies, but continue to available for prescription. So over the counter, you can buy and you can get it vaccinated. In 2016, Delhi State Cancer Institute started the HPV vaccination drive. And similar, in 2016, based on their India-IAC multi-center study, they have reported 2 dose and 3 dose efficacy are similar. So in 2017, Punjab initiated vaccination. They vaccinated, school-going children in 2 districts, Bathinda and Mansa, where the, cervical cancer incidence was 17 and 15 per 100,000. So in 2000 study, it was again reported there was similar efficacy of 1 dose, 2 dose, and 3 doses in prevented persisting HPV 16 and 18 infection. And apart from that, 2018, Sikkim initiated their vaccination drive, and in 2019, now it has been recommended that 2 doses schedule can be used for any girl child up to 18 years of age, which was 15 years. Now it has said, so the latest recommendation is 2 doses is valid up to 18 years of age. After that, you need to give 3 doses of vaccine. So what is the 2 vaccine which is available? Bivalent is Cervarix, which covers around 16 and 18. Apart from covering 16 and 18, it also gives a cross protection against 31 and 45. Quadrivalent is 6, 11, 16, and 18. Now we have, new, I think, addition to this. It's a Gardasil 9, which is a nonavalent vaccine. So apart from covering 6, 11, 16, and 18, it also gives protection against 31, 33, 45, 52, and 58. So still it's not available in India. So if anyone wants to get it vaccination, we must try to protect, the boy and girl from this, HPV associated cancer, which is going with very important, because we know that HPV association with the infection is an important consideration when you talk about the cancer incidence in India. So dose is what is 0.5 ml, and what is the dose schedule? Because if you give Cervarix, and if you are planned for the 2 doses for Cervarix or Gardasil, it is given, with the gap of 6 months. But when you are trying for the 3 dose of vaccine, so for the Cervarix, it is 0, 1, and 6, and for the Gardasil, 0, 2, and 6. I know everybody will be confused at every point of time. So C comes before G. So you remember, if you have to talk about 0, 1, 6, so remember Cervarix is C. So C is before G. So it will help you to remember. So 0, 1, 6 and 0, 2, 6 for the Gardasil. So what is our program? So we have the NPCDCS program. So we are covering cancer screening under this program, and it was started as a pilot in 2008. And in 2016 and 17, 616 districts were approved. Now it must have gone more than 700 districts in India. So we have a national framework in May 2016, after our Honorable Prime Minister said that we will be having our own framework for screening of common cancers in India. In November 2016, we came with the operational framework for screening of common cancers in India. And it was common cancers was breast cancer, cervical cancer, and the oral cancer. So to make it uniform, we started a screening in the age group 30 to 65 years. And with the modality for the oral cancer, it was oral visual examination. For the cervical cancer, it was visual inspection with acetic acid. And for breast cancer, it was clinical breast examination. And the frequency of screening was once in 5 years. So awareness is the need of hour. It is the driving force of cancer outcome in India. Probably the CAP theory applicable too much here, because we have knowledge, we have attitude, But when it comes to practice, probably the people who are educated, the people who are in oncology and in the other area of medical sciences, probably our practices are very bad, and doctors are always considered to be the worst patient. So we need to identify aware and pseudo-aware. Why I'm telling that, in the today's era, in the WhatsApp university or Facebook university, you learn so much, and probably you never know what is the application of it, but you want to use it. So people who are smoking 40 cigarettes a day, they will not bother about cigarette smoking. But when they go outside and ask for a cup of tea, and tea seller gives them tea in a plastic cup, probably they will, fight with him that you don't know, because you're giving tea in the plastic cup, it may cause cancer. So this is our pseudo awareness. We are not worried about talking 10 hours on phone, but whenever there is a, mobile tower is installed near to our houses, everybody is worried about radiation. So micro oven again, we are not worried about any other risk factors we are exposed, but we are so much having caution in not, putting any utensils which is in the microwave, so that it may cause cancer, because we all have heard it and we all have read it in the WhatsApp. So we need to make people more aware, and we need to tell them what is the definitive risk factor and what is the probability of having, cigarette as a risk factor for the lung cancer, and what is the, plastic to cause lung cancer or any other cancer is in the longer run. Medical checkup is not a priority. It's including, all of us, because we believe that we are living in a very strong social structure. So we have always four people who will, took us to the hospital, but we have now seen that many of the people has been diagnosed with cancer because of our attitude, and the major is the heart attack. We can see many of the, times young people are having heart attack because we have never pointed out medical checkup as a priority. We can, as I said, we can be a very good in teaching others, and we keep on trying that, but we never try to make that thing applicable to us. So campaign is very important, and awareness campaign, because now doctors might think that why this is for us, this is a duty of a social worker, but you think the amount of work and the efforts you are putting in your clinic or in your hospital, what is the outcome? Most of the time, you finish your duty doing palliation, palliation, palliation. So, if you want to improve outcome, you have to make sure that patient should come early. And in our rural background, where 70% of the people still live in rural area, you have to make an effective campaign to reach people, to make them aware that yes, you need to know about cancer, because now it's a very common in our society, and no family is spared from that. So lack of interest on the part of doctors, because we think that okay, this is not our duty. General population is always insane until and unless they undergo some crisis. If policymakers are so much of efficient and enthusiastic, we won't be discussing this thing. So lack of strategy based on local area needs are required. Funding for cancer awareness was a problem, but now everybody has understood its importance, and now you get the funding or you can arrange the resources for it. So important thing is how to implement that, because every area needs different kind of implementation strategy. So you have to learn it, and over the period of time, you will master it. So cancer prevention, these are the level of prevention. Probably we all have read the Park's test book, so I don't need to discuss this with you. So definition of screening. So what is important? CAP, local body involvement, screening of near to place. Probably this is a major issue. We advise people to go for screening. The next question they ask, where we should get ourselves screened, and we have no idea about it. Because if we say that okay, go to All Indian Institute of Medical Sciences and get yourself screened, so probably they have to go to the obs and gynae department to get themselves screened for cervical cancer. They have to visit ENT OPD for oral visual examination. They have to visit a surgeon for breast clinical breast examination. Probably in this whole exercise, somebody might take 6 months at a place like All Indian Institute of Medical Sciences. So after 6 months, you have to again go for next screening. So this is a very time-taking process. So you need to make things available. There is still a scarcity to it because nobody wants to invest in that, because that is not a very glamorous area and money minting process. So it's hopefully in coming days we'll have more screening center near to the people where they require general people involvement, family support and understanding. And one more important thing, doctor teaching and training is very important. Most of the people just go to the primary care physician for their complaint, and many of the time doctors miss the diagnosis. And I think training is very important over the period of time. Cancer and other NCD makes the major work of the diseases in the community. So you need to update yourself. So the doctor teaching and training will help them to understand cancer in a better way. And whenever somebody comes with such complaint, they can timely refer to the higher center. So cancer treatment challenges, many of the people who are working in the private or government, they all know what is our standard and challenges at right now. So lack of treatment facility, there is no uniformity. Many of the people have a fear of side effects, long waiting list, lack of multidisciplinary approach, and there is a follow-up issue. So in India, important context, we have changing incidence from Basi, which is having cancer incidence of 40 per 100,000 to the northeast, where we have the approximately 280. But the best part is that we have high occurrence of preventable cancer, so we can do something important about it. So there is a high mortality. Why? We all know that advanced stages presentation, access of care is very difficult, missing multidisciplinary approach, and still we are confused what we have to adopt. We are hardly doing the opportunity screening, but we have adopted right now population based screening with not much of success. So these are the challenges. We have rapidly expanding population. Many of the people ask, we Australia is doing this. So we as a country should be proud that we might be adding one Australia every year to our population. So we don't have to, adopt any other country policy. We have to think like an Indian way, and we have to find the solution for our country by thinking our way of doing it. So health insurance is still people are not covered, and there is a middle class 45%. And cancer is an important consideration because you always talk about out of pocket expenditure, and many of the middle classes are now been pushed to the poorer category because of the out of pocket expenditure due to cancer. Research is new, government versus private organization. There's always a fight. I don't understand why there is a fight, because then anybody you go and talk to the private institution, probably people don't consider it, because we all work for the people in India. So there should be no difference whether you work for the government and private. And nobody is born to work in a private hospital since his childhood. We work in the government hospital, many of the people study in, but they get a good opportunity, working opportunity, they go there. So academia industry collaboration is just like not considered to be a good sign here. And we hardly see any, like, for the drug and for any other modalities the people collaborate. But still in country like India, industry and academia collaboration is still pending, and we must try for that to innovate something new and to develop something new. So very important slide, we all should know about the false claim which is made by complementary and alternative medicine. They claim that they can completely cure, that they have master key to every cancer. Although I strongly, admit this is less documented, less research, side effect is less. I don't know. This is another misconception among the people. So CAM needs more research with proper documentation to reach the conclusion. And it is for everyone advises that till the time we don't have enough evidence, this philosophy should not be practiced in curing of cancer patient. So this is a best learning, to working for cancer care in last, I think, more than a decade. So cancer is always mistaken as cervical neck pain, and until and unless prove otherwise. I gave you an example. A lady came to me and said that, okay, I have taken cervical vaccine. Probably I will never have neck pain in future now. So pan is a good source of calcium. Somebody told me, because I was, parking my car in basement. So the guy who was looking after the facility was eating pan. So I told them, this is not good. You might have cancer in future. So he told me it's a good source of calcium. So probably next time in medical science, we believe in research. So somebody comes with hypocalcemia, we must try this modality to see whether what is the effect on the serum calcium level. In the youngster, this is always a confusion. They always want to justify what they work. So I have gone to Delhi University, many other university to take a lecture on cancer awareness. So many of the guy told me that, okay, if we smoke 2 cigarettes a day and exercise for 1 hour, it just wash out all harmful smoke. Probably it is a very interesting and challenging fact for me. What is the portal of exit? I don't understand where you take cigarette and where all the fumes and the harmful effects goes outside from the body. Chemotherapy does more harm than the gain. Many of the people try to convince other people, okay, you're going for chemotherapy, it's so bad. For a doctor, our only primary endpoint is to save patient life. We can manage the side effect associated with chemotherapy, but once the tumor progresses and it reached to a level, probably we can't reverse anything. Yoga can cure cancer. Probably yoga is a good thing that helps you to become healthy in your day-to-day life. But probably if you just claim that it can cancer, this is the next level. Gomutra can act better than chemotherapy. Probably thanks to Baba Ramdev, who has advertised Gomutra as a, it is good to clean the, I don't even think it is a good modality to clean your surfaces with the Gomutra, and forget about using it in instead of chemotherapy. So can Hanuman Kavach help us in cancer? So many of you must not be knowing what is Hanuman Kavach, because this is a very sacred ad they do in the television after midnight. So you have to just go on any television, and when I tried to search why people are so crazy about Hanuman Kavach, I came to know that if you want to order Hanuman Kavach today, the waiting time is 3 months. So probably after that, I felt, I stopped, feeling bad when we give 3 months or 4 months waiting for the radiotherapy and surgery. But people can wait Hanuman Kavach for 3 months. So this is all about, you know, hope, and many of the people are selling hope. So why don't you take help from Nirmal Baba and Baba Ramdev for cancer care? This was the epic one. Probably many of the people who are praised and who are advising others to go for Gomatra Panchagab, when they are suffering from cancer or any family member is suffering from cancer, they come and either they are treated at high center, or they go to the private to save their life. So I can control cancer my willpower. So this all exercises tells us that yes, there is a lot more to do to teach our population, which are very insane, has no idea what is cancer. And many of the times you meet many educated people with what kind of understanding they have about the cancer, the risk factors, the treatment. You need to think again. So they are educated, but they are not cancer educated. So it's a responsibility of every oncologist to do something to help other people to decode the mystery of this disease. And it's not so difficult, it's easy, and we can always do it. So this is many of the people who have seen in the advertisement of this pan masala, and lost their parents due to cancer, but don't understand. After losing their parents to cancer, they are still, if they get money, they can advertise anything. So in spite of that, they also talk about farmer, the tobacco farmers. You need to protect your livelihood. And this is a good one. When I saw one day Times of India, there was a caption, what the hell this James Borden doing in a Pal Masala ad? If anybody get the answer of this question, please let me know what the hell he was doing in a Pan Masala ad. Doctors are not less, because ITC stand for Indian Tobacco Company, and Indian Tobacco Company hotels, IT hotels are best hotels in the country. So we don't mind, giving them again revenue and organizing many of the conferences that is based on cancer at a venue which is built up, from the revenue of the cigarettes. So this is, we need to stop it. LIC. When I tried to search what is the major investment in ITC, I found that LIC, which is Life Insurance Company, many of you having a policy with LIC. And I found that maximum investment in Indian tobacco companies from LIC, that is what I able to understand their slogan, Jindagi ke saath bhi aur Jindagi ke baad bhi. So when you are smoking also, LIC is getting the benefit. And when you die after smoking, when you develop lung cancer, probably LIC is the beneficiary. So what we undergo day-to-day life, we see many of the patients dying because of suffering. So before talking about the farmer rights, everything, we need to see this photographs, and we must understand that what is the life of a cancer patient. So you should not justify whatever wrong you are doing. So this is a epic one, blaming friend for throat cancer, man kills him. I don't promote the violence, but there's a story that I want to share, that one guy who just, started doing smoking, and he later on developed the throat cancer. He remembered who was the first person who introduced him to smoking, and he just got, he fired on him, and he killed him because he thought that he is the one who introduced him to smoking and made a way to, for the cancer to happen. So whenever you smoke, so probably I will advise you to remember the first person who introduced you to smoking. So whenever you have any kind of, pathology in future, probably you should remember the name. I'm so sorry for this, but this is very important learning. I don't promote this, and this is eradication. We need to work on prevention and screening, and eradication is not for the medical health professional and not for the oncologist. So what is needed? You need to have a brand ambassador. You can see there are many brand ambassador for the pan masala, but we don't have brand ambassador for cancer care. There was Rahul Dravid was brand ambassador for, but we need to effective this is counter tobacco, anti-tobacco campaign, because the way they are promoting the tobacco use and through the different marketing strategy, we need to adopt it. Media should be more responsible, medical fraternity as a role model, and we should not smoke and drink in our conferences if you want to teach others. So involvement of NGO is very important. They have done remarkable work in TB and AIDS. So theater and cinema has done so much for many other social issues. So cancer, they should always take it up and they should do something. Cancer and addiction should be taught in detail so that they can understand this. And we must advertise, because you may be knowing everyone in the frame, but we are not aware about, because doctors are not promoting themselves and not promoting their work. So we need to now promote our work and promote the learning to the people so that they can learn. So this is my concluding slides. And I strongly believe that I in illness is isolation. So we don't have to be isolated, and we don't should believe in the I concept, and the crucial letter in wellness are we. So we should work together. And in the COVID-19 pandemic, this has really taught us so many good learning, and we have to take it forward. And we are, because we need to be healthy, because healthy communities have hope, and those with hope have everything. So we have to be optimist and try to convert every difficulty in opportunity, rather than working like a pessimist who thinks every opportunity has a difficulty. Thank you so much for this opportunity once again. Over to the organizer.
Thank you, sir. Thank you so much. It was indeed a privilege to listen to you, and it was a wonderful lecture, and a lecture that was thoroughly enjoyed. Sir, I have a couple of questions regarding the screening and prevention of cervical cancer.
Yeah, please ask me.
Sir, in India, we see that particular community where the men undergo circumcision early in the childhood. In that community, the women, they don't, they have very, very less incidence of cervical cancer.
No, I think this is not true, because many of the times in the same community, it depends that what is the risk for cervical cancer. Early age of marriage, if you have more number of children, probably your chances of circumcision helps you to HPV infection in the counterpart, but that doesn't prevent the infection in the women. So it's not like that community is not having cervical cancer. They are having in many of the cases, because the risk factor for cervical cancer is early age of marriages, more number of children you're having, so they are exposed to more kind of trauma and more chances of HPV infection. HPV infection is the most common infection worldwide, but it is self-limiting. That's why you never try to go for the HPV DNA. That is the rationale. Because many of the times, if you try to do it in 21 to 30 years of age, you may find the HPV positive, but over the period of time, they just disappear. Okay. So many of the women suffer from that. So this is not because it's very common, and its more common risk factors is the more number of children.
Okay. And so, like, because of the uh, less resources and screening opportunities, if we go for screening, if a patient goes for screening for one particular type of cancer, so can we design the program in such a way that at the same doctor does the screening for other types of cancer also? Like if the
Yes,
patient,
that
then
is that is what is needed, because and who will take this responsibility? Because for us it is easy because we are good in looking at the oral cavity. We are good in doing, because for other patient we are used to do the per vaginum examination. For our cervical cancer patient, we always go for the oral examination. We just do the breast examination. So radiotherapy people have a critical opportunity to take this opportunity to screen their patient, and you should start the facility. But otherwise it is very, very difficult for other people to take up this assignment, like for the surgeons, for the gynae, for the ENT. Probably they can see one area, but they don't have any idea about the other area where screening is important. So that is an important domain, and radiation oncologists should take this opportunity to develop something. And if you need any kind of assistance, I will be very happy to assist in that program. And because I have a written program, how we can, because we started the preventive oncology, and we used to do that. We have screened many of the women, at All India Institute of Medical Sciences for different kind of cancers. And that was under one roof. They don't have to visit any other area for screening, because if they have to, age specific cancer screening requires uh, screening of for the colon cancer also. We did that also. Low dose CT scan, we have get it done for many of the patients. So age specific cancer screening we must start, and we must do that.
okay. And sir, we have a question from Dr. Manish. He's asking, uh, HPV vaccine for more than 21 years. Can we what
Yes.
is the
So a standard recommendation is 9 to 26 years. And now many of the trials says it is safe to use till 43 years of age. But your problem is that about the efficacy. So 9 to 26 years they have been recommending to use this. So after 20 years, but up to 18 years of age, you can advise for the 2 doses. After 18, you have to advise for the 3 doses of HPV vaccine. So it is advisable.
okay.
But
And,
best time to use it in 9 to 12 years of age, so which is recommended in other part of the Western world.
and sir, what are your views regarding HPV vaccination for oropharyngeal cancers?
These are not recommended, but this is not recommended because still they have found that uh, male vaccination we have not yet started. Still in India, we are talking about more of a HPV vaccination in a girl child. So you can start because it prevent the anogenital ward 6 and 11. So you can start this thing. But as far as the recommendation for HPV vaccination as a prevention to the oral and oropharyngeal cancer, US Preventive Services Task Force doesn't recommend it. Any kind of recommendation, they have not yet supported to go for for vaccination to prevent oropharyngeal cancer.
So in India, can we try this on a pilot basis? So what is
India, I think for vaccination related, there are, because it in litigation, so still people are trying on the over the counter basis, but still it is not allowed to do any kind of trial related to the HPV vaccine because it's still in the court. It's pending. Its hearing is going on, so you can't do that. Any kind of research, it's not it allowed in the trial basis. It's not allowed till now. So over the counter, you can take it, you can vaccinate yourself. But government has, restricted this, and this many of the people have tried it. You see the IAP recommendation, they recommend HPV vaccination for child, but it's still not part of the program. So oropharyngeal, you have to just have a long follow-up. You start the vaccine, then you have to just do the follow-up. Probably in your thesis or something like that, you can think of starting that. But trial is not possible.
Okay, sir. Are there any other questions from anyone? Please feel free to unmute and ask. Okay. So, sir, it was really a privilege to have you here on Teachers' Day. And we are really grateful to you, sir, that you have spent your precious time and educated us all. And we hope that this helps everyone. And thank you so much, sir, once again.
Thank you.
Happy Teachers' Day and happy Teachers' Day to everyone.
Enjoy your Sunday. Thank you. Bye.
Thank you, sir.